In today's lecture, I'm going to be talking about the relationship between health and development. In development studies, of course, what we are often more interested in is the relationship between illness and poverty, because many of the places that we do our research tend to be in poorer settings, and we're often interested in looking at how poverty causes ill health, and also how ill health causes poverty. So the first thing we're going to look at is the relationship between development and health at an international level. The second thing we'll look at in this lecture are the concepts of susceptibility to illness and vulnerability to illness. These two concepts, susceptibility and vulnerability, are very useful for looking at what causes people to become ill, and then once they're ill, what enables them to get better, what gives them the capacity to cope with illness and to seek treatment and to get better. And we'll illustrate those concepts by using a case study of HIV in Uganda, and we'll look at people's susceptibility to HIV and people's vulnerability to HIV. Poverty and illness are interrelated. In other words, if we take poverty or deprivation and we look at how that causes ill health and disease, we can look at the concept of susceptibility to illness to help us do that. Poverty causes susceptibility to ill health or disease. For example, in a poor environment, in a poor household, you may not have access to clean drinking water, and so that can cause diseases of poverty such as diarrhea. We're also interested in the relationship the other way. So once people become ill, what is it that allows them to cope or that forces them into poverty? And this is where the concept of vulnerability to the effects of illness comes in. Once you're ill, what capacity do you have to cope with illness, to access treatment, to be able to pay for treatment, and to get better without becoming impoverished? The first thing we're going to look at is the international setting, really. What is the relationship, in very broad terms, between income per capita or income per head on the one hand and health? And the indicator of health that we will use here is life expectancy at birth. Over the next few minutes, just have a look at this graph, and in your class you might want to discuss briefly the relationship between national income per capita, or per person, which is this horizontal axis here in US dollars, and the vertical axis, life expectancy at birth in years. What does this broad pattern of all these countries tell us about that relationship? If we look at a bigger version, I think the first thing to notice is that there is a very steep relationship between national income per person and life expectancy when countries are quite poor. So if we look at countries where the national income per person is between 0 and about 5,000 US dollars per person, we can see that as income increases there, so life expectancy dramatically increases from around 45 up to about 75. In other words, it only takes quite small increases in income per capita to have a huge effect on people's life expectancy. And that's because it's just the very simple things that can improve health: clean water, better food, better nutrition, access to basic health services. These are small things, but can have a huge effect on people's life chances, particularly when they're young. As countries get richer, the relationship between wealth and life expectancy starts to become slightly different. The slope is shallower. We can see now that on this second line, the relationship shows that you need quite large increases in income to have an effect on life expectancy. And I guess that's because once you've achieved the very basics, it costs a lot more to achieve even better health. In addition to this very simple shape, I hope some of you will have noticed that there are some countries that don't quite fit the pattern. For example, if we take Costa Rica or Cuba, we can see that despite having quite a low per capita income of around, if I can find the cursor here, of around about 7,000 US dollars per person, their life expectancy is nearly 80. In other words, something's happening in those countries to make people healthy. It's not just income. There must be other things going on. Government policies, the distribution of wealth. Similarly, Nicaragua, we could take that as another example of achieving better health than we would expect. In contrast, if we take South Africa, despite its relative wealth as a country, and we can see that South Africa has a national income per person of about 13 or 14,000, its life expectancy is still very low, only about 50 years. Now, why is that? Well, I think some of you will already be starting to realise that it's not just the wealth of a country that's important, it's how well that wealth is distributed across the population. In an unequal society, in a society where there are very different levels of wealth between different groups of people, that means the wealth isn't distributed fairly or evenly, and that means many people won't have good health. Of course, we could look at places like Botswana, Lesotho, Swaziland, Zimbabwe and Zambia. These countries also have low life expectancy at birth. Of course, there's something else going on here as well, and that's HIV and AIDS, because these countries in the southern part of Africa have a very high prevalence of HIV, and that is also having an effect on these populations. Another way of looking at this relationship between GDP per person along the horizontal axes here, or national income per person, and health, or life expectancy at birth, is by showing a graph that has every country, and the size of the country's circle is dependent on its population. So here the big red circle is China with a very large population. Russia is the big orange circle here, another large country with a large population. India, also a very big circle, a huge population. And we can see that Japan and the USA also have quite big populations. And there are some obvious patterns going on here in terms of international differences between regions. Japan, highlighted there in the yellow circle, is doing very well. And in fact, Western Europe, USA, Japan, these are all countries that are both high income and have a very high life expectancy. A second group of countries, Latin America and Eastern Europe in particular, are also doing reasonably well, and their life expectancy has been improving over the last 30 to 40 years quite dramatically. A third group of countries is East Asia, China notably, also Indonesia, the Philippines. These countries are also doing well, and their life expectancy has been improving dramatically as their income levels start to rise. Fourthly, South Asia, India, Bangladesh, Nepal. These countries aren't doing so well, but they're still facing gradual improvements in life expectancy. And finally, the poorest countries on the whole, and the countries with the worst health outcomes, the lowest life expectancy, are the countries of sub-Saharan Africa. But we can still see these outliers that we looked at before, these countries that don't fit the pattern. South Africa, relatively high income per person at 10,000 US dollars, but very low life expectancy. And again, we can see Cuba and China there doing pretty well. This graph is just to illustrate what effect HIV and AIDS has had on life expectancy in parts of Africa in particular. So if we take the three lines at the top here, the orange line, the blue line and the black line, these are the countries of Botswana, South Africa and Zimbabwe. And this is life expectancy at birth again. And along the horizontal axes we have time from 1950 to 55 through to 2000 to 2005. And we can see quite clearly what has happened to some of these southern African countries. If we take Botswana, from 1950, Botswana had tremendous development achievements over time, improving its life expectancy, going up all the way up to around 62, 63 years by around the mid-1980s, early to mid-1980s. But then we see what happens to these countries. I've lost the cursor. Here it is. We see what happens to these countries from around the early to mid-1980s. We can see life expectancy dropping, going down, 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 all the way to around 37 by 2000 to 2005. And that is the effect of HIV. Life expectancy at birth declines because young adults are dying in large numbers between the ages of 20 and 40 because of HIV. I wanted to end this first section of the lecture by just explaining life expectancy as an indicator a bit more. And if we take a country like Burundi in 2007, and we can imagine there are 5 people, Pierre, Lee, Jay, Anne and Sarah. Now, in a country like Burundi, where life expectancy is 50, we will still expect to see older people. People don't just die when they get to 50 years old. There are many people who live into their 70s and 80s. But unfortunately, there are also many people who die at a much younger age, as children or young adults. And this means the average life expectancy is reduced dramatically. So if we took these 5 people and asked how long will they live, if conditions remain in Burundi in 2007 as they are now during their whole lifetime, then we can see what happens. Pierre, unfortunately, dies at the age of 1 year old. Lee, she grows up and lives to about 36 years old, but then dies, perhaps in the setting of Burundi from HIV and AIDS, but it could be a car accident or another tragedy. Jaya, he lives to 57, still quite young, really, in the scheme of things. Anne has a better life in terms of its duration. She lives till 72, and Sarah lives till 84. Now, life expectancy at birth for a country is simply the average of all the ages that we can expect people to live, taken from figures such as this. And so we can see that in Burundi, we calculate the mean, which is 1 year plus 36 years plus 57, 72 and 84 divided by 5. That gives us an average life expectancy of 50 years at birth. Now what these figures tell us in particular is if we can improve the health of young people, if we can reduce infant mortality, for example, if Pierre didn't die at 1 but lived till 70, that would have a huge effect on life expectancy at birth. So basically, to increase life expectancy, the first place we should focus our attention is on making sure young babies survive and making sure we reduce infant mortality. If we can reduce infant mortality and stop a lot of young babies dying, life expectancy at birth increases dramatically. If you're interested in seeing some more of these graphs about life expectancy internationally, across countries, have a look at the video on YouTube, which is a very interesting and dynamic way of looking at changes in life expectancy over the last 200 years. And also go to the Gapminder web pages because they have some very interesting graphs and videos for you to look at there as well. So this is the end of the first part of the lecture. The second part of the lecture starts to look at susceptibility and vulnerability. This is the second part of the lecture where we're going to look in a little more detail and explore the relationship between economic growth and health a little more, and ask the question, how does that relationship actually work? And in particular, we're going to use the concepts of susceptibility and vulnerability to look in much more detail why the relationship between income per person and life expectancy isn't always an obvious one, and why there are many other factors operating that influence the health of populations. I use the examples of South Africa and Costa Rica here just to remind us about how different factors operate to influence health, not just income alone. So let's look at susceptibility in a little more detail, and we'll start by looking at how poverty causes susceptibility to illness at the household level. So here we have poverty, and it's moving through with the green arrow to the notion of susceptibility to illness, or risk of disease, or becoming ill, through to ill health. Now, at the household level, what factors contribute to susceptibility? How does poverty cause ill health? Well, there is obviously income poverty and how that affects things such as access to food. But we know that access to food isn't just about income. It's also about one's position in the household and whether one can access the food that's available to other members of the household. Perhaps if you're a young child or if you're a woman in the household, you may have less access to food than males, for example. Access to clean water, that's another key factor that contributes to better health, but if you don't have access to clean water, then you're more susceptible to illness. Education is also a very important factor in people's susceptibility to illness. It's another aspect or dimension of poverty, and low education can mean people are more susceptible to illness because they don't understand necessarily what causes illness. And so they may not take precautions to prevent illness. Women's education in particular is important because that influences how young children are brought up, how they're fed, how they're looked after, and whether they're taken for treatment when they're ill. Access to preventive healthcare to stop you becoming ill is also crucial, and that's things such as immunisations or inoculations against certain diseases. So immunisations against measles, tetanus, mumps. These are all vital things to make babies more resistant and less susceptible to illness. Antenatal care for pregnant women is also a very important intervention that can help prevent unnecessary illness or even death. Now, in situations of poverty or lack of development, all of these things combine to create susceptible environments, high-risk environments where people become ill quite frequently. And usually they become ill through diseases of poverty or communicable diseases. Communicable diseases is not an easy word. This is diseases that are spread from one person to another through bacteria or viruses. And I mean, the first basic disease of poverty is malnutrition, but that in turn can make people more susceptible to other illnesses such as chest or respiratory infections. This is a big cause of child mortality. Diarrhea, a horrible spelling, get to know that spelling, but diarrhea is also another big killer of children and a big cause of illness. Other infections. And of course, in settings of poverty, serious diseases such as tuberculosis and HIV, the human immunodeficiency virus, are also more common for a whole variety of reasons that we'll look at in detail through the case study in a moment when we look at HIV. But what about poverty and susceptibility to illness at a bigger scale, at a national or a country level? Because I think if we ask the question, why do some poor countries actually do quite well in preventing illness, whereas other poor countries don't, and in fact, why do some better off countries, such as South Africa, why don't they do so well in preventing health? And once we look at bigger national level factors, country level factors, we can identify several things. I mean, again, economic growth and income is one factor, but more importantly, it's the distribution of wealth. It's levels of equality or inequality. They are the things that really drive health or not. And that distribution of wealth, if you like, is crucial. So, for example, a government that taxes the better off and spends money on healthcare services and basic services for the whole of the population is going to provide, I think, a better health environment, a less risky environment than what in a country where the wealth is concentrated in a few hands. Now, linked to the distribution of wealth is what we might call social structures in society that cause inequality, and I've selected two here: class relations and gender relations. So, taking class relations, what I really mean by that is who are the people that have things and who are the people that have less in a society. For example, land. In some societies, land is unequally distributed, and that means that some people are marginalised. They don't have access to land, they can't grow enough food, and that causes problems. They may get paid less, they may be paid very low wages, which again means they can't access food and they can't access treatment for healthcare, treatment for diseases. Gender relations are another important factor. Gender inequality is one of the biggest factors causing societies to have less health, if you like, because if women have more power and autonomy to make decisions in the household about, for example, children's health, if they have the power to take children to the doctor, that can have a huge effect on the health of a family and the health of a community, and therefore the health of a society at large. And so we start to see the importance of the nature of government and politics as a factor influencing the health of a country, and social movements that put pressure on governments to do things. If a government spends money on healthcare, if it invests in maternal and child health care, and if people are pushing it to do so, then that can have huge benefits for the population. So government and politics and policies are crucial. So if we look at service provision, healthcare services, they're crucial. Water and sanitation services, they're important as well. Education policies and services, giving people access to education, these are also important. And when it comes to healthcare, making sure that healthcare is not just available, but affordable. Can people afford to pay for treatment? Do they need to pay for treatment? In the UK, for example, the government provides healthcare free at the point of delivery. But in a place like South Africa, you have to pay for your healthcare, even though you're poor, and that can cause huge problems for people accessing treatment. I'm not sure how healthcare is provided in Japan, but I suspect there is probably a social insurance system, which means when you become ill, you don't have to pay when you go to see the doctor, or if you do have to pay, you can claim the money back. So how would susceptibility at the household level work in a place such as Uganda? And I've decided to use a case study of susceptibility to HIV in rural Uganda. So let's take a case study of susceptibility to try and understand it a little more. And I want to look at the case study of susceptibility to HIV in rural Uganda, looking at both household level and country level factors. And if we take this household in the picture here. This is a rural household in eastern Uganda. And I've got a map of Uganda here in the dark brown. And we can see Lake Victoria, the huge Lake Victoria to the south of Uganda here. And this is the eastern border of Uganda alongside Kenya. And the border goes round to the north and then down to the west of the country here, all the way around to the Tanzanian border and across the lake again here. Now, this household that we were looking at is located just outside the town of Tororo, which is only a few miles from the Kenyan border. So, why would the people living in this household be susceptible to HIV, both men and women? Well, let's tell a story very briefly. Living here is a woman, and she has HIV. She's been living with HIV for about 10 years, and she caught HIV from her husband. Now, this all happened because about 10 years ago, her husband was travelling to and from Kenya. They were living in poverty, and the husband decided that to make more money, he could go to Kenya, buy commodities or products such as clothes, and bring them back to Uganda and sell them at a higher price. Things were cheaper in Kenya, more expensive in Uganda, so he could get a good profit. And when he started this business of trade across the border, it was very successful, and he made quite a bit of cash. But that success and that travelling away from home a lot meant he, if you like, started to meet other women, and he had some relationships outside of his marriage. And in the end, that's how he caught HIV and then brought it back home, and it spread to his wife. Now, this is a tragic story that's affected many people in this setting, and we can start to see some of the reasons why people here in particular are susceptible to the infection, to HIV spreading. We could start by looking at the fact that this area is poor, people living in poverty, and they need to earn money whichever way they can. In this case, it was travelling to and from Kenya across the border and spending a lot of time away from home. Similarly, we can look at gender inequalities. So the man would travel away, he would come home, and the woman had no, even if she suspected that he may have been having extramarital affairs, she had no power to demand any action by him. She had no power to ask him whether they should use a condom or not. So she was very susceptible and at risk to catching the virus in that way. We can also think about lack of education in this area. So people at this time were not so aware of HIV. I mean, they are now. In this setting, people are very aware of HIV. But 10 years ago, they were not, because that was before the disease had really taken effect in this area. So we can see some of the factors: poverty, gender inequality, trading across the border, people moving around a lot. These are all factors that drive the epidemic. Now, if we look at this map of Kenya, it's actually a map of Kenya, but you can see Uganda there as well. And again, we can see Lake Victoria here and Uganda here. And here's Tororo, that's the orange circle here. And then just further south, along the coast, amongst the fishing communities here, HIV prevalence is very high. And again, that's because of the susceptibility to fisherfolk to HIV. They're travelling to and fro across the lake, going to one settlement after the other. They make a landing of fish, they catch fish, they sell it, they earn money. There are bars there, there are sex workers there. And so people are very susceptible to the HIV virus in this setting. They have risky livelihoods, if you like.
So far, we have been talking about susceptibility to illness. We'll now finish the lecture by looking at the other side of the diagram to look at vulnerability to illness. And we'll start by looking at vulnerability to illness at the household level. Now, the key question here is, once a person becomes ill, do they have the capacity to cope? Do they have the capacity to seek treatment and get better, and therefore not fall into poverty as a result of illness? And we can ask several questions. Do poor people have the ability to access healthcare services when they're ill? Can they afford those health services when they're ill? And therefore, do they have the capacity to cope and manage with the illness? And we can look at several factors that influence vulnerability to illness at household level. And we call them household level factors affecting capacity to cope. Now, the first one is the type of disease. Obviously, a minor disease, such as a cough or cold, isn't going to cause too many problems. It's self-limiting. People will get better, maybe just take some paracetamol, which aren't that expensive. But a more serious illness, such as malaria, that requires expensive treatment if it's not provided free by the government, or even more serious, something like TB or HIV, these require very expensive medicines, and if poor people haven't got access to cheap medicines, they're vulnerable, and they will have to either not get the treatment and perhaps be very sick and even die, or they will have to borrow money, sell assets, and spend all their savings, if they have any, to pay for treatment. So household money and the resources available to them are important factors influencing vulnerability. Access to affordable health services, education and treatment-seeking behaviour. In other words, do people know which services to go to that are effective, or do they waste time and money seeking other services, say, for example, traditional medicine, which may not actually be effective in dealing with something like HIV? Now, we can look again at the household we looked at earlier from Eastern Uganda to just give some examples of this vulnerability. If we look at this household here, we can think, okay, severity of illness, HIV, that's a very serious illness, it's a long-term illness, and people spend a lot of money going from health provider to health provider, trying to find a cure for this incurable disease. And until free antiretroviral therapy arrived in Uganda, ARVs as they're called, there wasn't anything people really could do to deal with the disease apart from ensure they get antibiotics when they get illnesses. We can think of, okay, how did a poor household like this, which can't even afford the transport to get to the nearby facility, what does it do when its members are falling ill? Well, it starts to sell assets. It sells chickens, it sells pigs, it sells cows. They may sell land. They may take the metal sheets off their roof and sell those. And eventually, the whole household becomes impoverished as a result of illness. And I'd advise you to have a look at the chapter by Sabin and Miller that I've recommended for reading, because that looks at the impact of HIV on a vulnerable household in the South African
setting, I think. We can also look at the impact of HIV using a livelihood framework, which basically looks at the social context in which people are living here. We might call this the vulnerability environment. You know, is there work out there? What's the general level of poverty? Do people own their own land, or are they actually living on very small land plots? What's the social context in terms of the institutional environment? Are there accessible and affordable healthcare services nearby? So the policy context and the resources within which households are living are important, but then we can think through some of the resources or assets households can draw on when they become ill. They can draw on their human capital, their education, their knowledge, their ability to know which providers to go to. They can draw on their financial capital, money they have available in their pockets or savings. They can also draw on their natural capital. They may have land, they may have trees that they can sell, productive assets. So if they sell these, that may lead to impoverishment further down the road in the future. Important at times of illness is social capital, people's social networks, their friends, their relatives, that they can go to and ask for help when they're ill. They might borrow money, they might ask for food, they might give the children to an aunt or an uncle to look after because they're very sick. And of course with HIV, when people became very, very sick, they had to rely on social capital.
but of course that social capital was often decreased or reduced because of stigma. Physical capital, that's just a whole range of other assets that households have. We've talked about them to some extent. Parts of the roof they could sell, bicycles, sewing machines, and finally personal capital, one's own motivation and drive and planning abilities to know what to do next and to make decisions. And these are all ways we can look at household resources and how they influence vulnerability or ability to cope with illness. And if they have these, then they can cope well, and therefore the impact on poverty will be less. So that's at household level. Now if we look at country level, the factors at country level that are important, so we can think about the disease burden in society. So if the HIV epidemic is very widespread, that's going to impose a large burden or cost on the community, on health services, because people are going to hospital a lot. And so does the government and have the capacity to cope with that disease burden? We can think about government or state resources and the allocation of those resources to public services. Is the government competent? Is the government committed to providing essential health services for people, or is it spending money on other areas of priority, a war, military expenditure, or so on? And that can influence the health of a nation. The types of service provision. Is it providing primary health care at the very grassroots to enable people to access care, or is it concentrating a lot of resources at the top of the health system in hospitals? That can be important, but for the vast majority in poor societies, it's primary health care that's important. And the political context can also be crucial here. We can end the lecture by returning to this diagram that we looked at the start, the relationship between income per head and life expectancy. And we can summarise what we've been talking about with 3 or 4 key points, really. We can summarise that economic growth is important to health, and this diagram clearly shows that. But we've also seen that just as important is how the economic benefits are distributed across society. And again, if we look at the example of Costa Rica and Cuba on the one hand, or South Africa on the other, we can probably start to see that there have been very different government policies that have influenced the population's susceptibility to illness and their vulnerability to illness. For example, in Costa Rica, the government has provided policies that reduce people's susceptibility to illness. They have invested in healthcare services and primary healthcare. They've invested in making sure there is clean water available to everybody. They have invested in making sure people have enough food to eat. They have invested in access to preventive healthcare services and to antenatal care for women. In contrast, in a country like South Africa, despite its great efforts in recent years to increase the equity and distribution of resources, there is a long historical legacy of inequality. And you've probably know about the apartheid system that used to be in South Africa before Nelson Mandela was released from prison. And in that system, society was very unequal, and that has been continuing really, so that the government has struggled to make sure people are not susceptible to illness. Education services are still limited, basic healthcare services are still limited, and there are still great inequalities in income and wealth. Similarly, Costa Rica has invested in government services that reduce vulnerability to illness, whereas South Africa has struggled to invest in those services to reduce vulnerability to illness, partly because it lacked the resources to deal with a very large epidemic, the HIV epidemic. So again, these issues of susceptibility and vulnerability and what governments do to affect those help us understand some of the countries on this graph that don't fit the pattern. And so some conclusions. We've looked at the relationship between poverty and ill health. We've looked at the relationship between development and health. And we've looked very briefly at a conceptual framework that talks about susceptibility and vulnerability, and these concepts help us understand the interrelationships between poverty and ill health. And we've also looked at the factors affecting susceptibility to illness at household level and at national level, very briefly. And we've looked at the factors affecting vulnerability to illness at household level and at national level. And we've seen that in a place like Uganda, households were very susceptible to HIV and very vulnerable to its effects. And HIV did indeed cause a lot of impoverishment in these settings. But the good news is, to end, is that in the last 10 years, 5 to 10 years, more and more antiretroviral therapy has been distributed across places like Uganda, and people are literally coming back from the dead. They're getting better. The key question is, how sustainable is the financing of all of those expensive medicines? And those medicines are usually financed by international donors. A big development question, and there I'll end. Thank you for listening.